চাবিটা একটু বের করে দিয়ে যান, কোথায় আছে? এটা কি সাধারণ জানেন? এটা কি জানেন? হ্যাঁ, যায় না কেন, দেখা যায় না কেন?
Thank you for a nice introduction. Ladies and gentlemen, and my teachers here present over here, I'm Dr. Hassan Shahriar Kollol. I'm actually not a psychiatrist, but I used to work in NIMH for a long time, actually for 3 years, during my early career. So I'm very much affiliated to this society. So I did a study on mental health status among primary caregivers of cancer patients in Bangladesh. So I'm going to present this case. Actually, it was done by 3 of us, myself, Dr. Ashraf and Dr. Shaun. So I'm presenting on their behalf. So you know that cancer is a major global problem, health problem, with higher levels of physical and mental health burden on the patients, their families, and healthcare system. The incidence of the cancer is increasing globally and at the same time very rapidly in Bangladesh, with many patients presenting at very late stage of the disease. However, the mental health status of the primary caregivers of cancer patients is yet to be explored. So we aimed to assess the mental health status of the primary caregivers of cancer patients attending in a tertiary care hospital in Bangladesh. Before going to my study, I want to present some data on Bangladesh cancer scenario. The source is Globocan. It was published in 2020. You can see that the total population is 164 million, and the number of new cases, just see, 1,56,775 new cancer cases per year, with a number of deaths 1,08,990. If we see the organ-wise or organ-specific cancer, then esophagus cancer is the highest, then lip and oral cavity, and then the third position secured by breast cancer. In males, esophagus, lung, lip and oral cavity are the highest cancers. In female, breast, cervix and esophagus. So, the drawbacks in cancer treatment in Bangladesh. We have actually fewer cancer care facilities in the government sector. That's the very difficult situation for the cancer patients, because you know that the cancer treatment is very much expensive, and most of the expenditures are out of pocket of the patients. And at the same time, cancer treatment is quite complex and expensive as well. The patient has to undergo surgery, chemotherapy, radiotherapy, immunotherapy, hormone therapy, targeted therapy, so many complex treatments. And the duration of the treatment is very, very long. So any patient suffering from some infective disease, he just come, take some medicine and then get cured. But for cancer, you have to go through all the treatment modalities, and at the same time, you have to go for a long follow-up, which are also very much expensive and troublesome. In this scenario, the mental health aspect of cancer is rarely addressed. So our objective was to assess the mental health status among the primary caregivers of cancer patients at a tertiary cancer center in Bangladesh. If we more specify our objective, the specific objectives are to assess the mental status of the primary caregivers, to find out the extent of mental health problem among the primary caregivers, to determine the contributing factors behind the mental health problem of caregivers, and finally to find out the socio-demographic pattern of the caregivers. Our method of study was a survey. Primary caregivers of admitted patients at National Institute of Cancer Research and Hospital, where I'm working, which is the only comprehensive tertiary cancer care center in public sector in Bangladesh, was the study population, and our sampling method was convenient sampling. Our sample size was 290 caregivers, irrespective of age and sex. Our tools were the DAS-21 scale, the depression, anxiety, and stress scale 21 items, and also the Zurich burden interview scale. We estimated the proportions of participants who had emotional states of depression, anxiety, and stress, and examined their correlates using logistic regression to yield adjusted odds ratio with 95% confidence interval in Stata 16. So this is the characteristics of the study population. Total number of participants I have already mentioned, 290, and most of them are actually, you can see most of them are female. If you consider the age group, most of the caregivers are from 30 to 45 years and 45 years or more. The educational attainment, if you consider, most of them are having no education or primary education. That means our government hospital, most of the patients coming there are from lower socioeconomic status, at the same time lower educational status. If we consider the employment status, we can see that most of them are unemployed or housewife, because they have to stay longer for months together or sometimes years together with the patient. Caregiving characteristics. We try to see the relationship with the cancer patient. Most of them, actually 63%, were either parents or spouse. And I have mentioned that most of the patients present very late in our country. And in our study as well, we see that around 70% of the patients presented very late. The duration of caregiving, duration of cancer diagnosis in months. So our median was 9 months. Treatment cost was around 1800 USD, because we actually wanted to publish this paper in a foreign journal. That's why we calculated this in USD. So it is near about 2 lakhs taka in Bangladeshi taka. So the type of treatment received, I mentioned that they have to undergo lot many complex treatment modalities: radiotherapy, chemotherapy, surgery, and some combination therapies. That means the mixture of surgery, chemo, radiation, etc. The duration of caregiving in months, median is 7 months. And caregiving responsibility, we try to assess that whether the sole responsibility and responsibility shared with others have any association with this mental burden or not. So this is the distribution of negative emotional states of depression, anxiety, and stress among family caregivers of cancer patients according to DAS-21 scale. And you can see that the moderate, severe, and extremely severe, that means around 50% of the caregivers have moderate to severe depression. Around 25 to 30%, they have stress, and around 60%, they have moderate to severe to extremely severe anxiety, which is very significant. That will be proven later. And the Zurich burden scale, mild to moderate burden, 44.1%, moderate to severe burden, 35.2%, and severe burden, 4.5%. Now, the association between emotional state of depression and various caregiving characteristics. So, relationship with the cancer patient, no, there is no that much association. If we consider the stage of cancer, this is very significant. That means the higher the stage of cancer, the higher the burden, because the cost and everything, the duration, everything get longer with the advanced stage of cancer. The duration of cancer diagnosis is also significant. You see the odds ratio is 2.41, which is very much significant. That means the duration, if the duration of cancer is 6 months or more, the burden increases. So I'm actually at the middle of my presentation, but still. So cancer treatment is not significant, but you can see that in a country like ours, it is around 2 lakhs taka at least. Most of the patients have expend. Now, the type of treatment received by the cancer, this is not significant. The duration of caregiving is very much significant. If the duration of caregiving is 6 months or more, then the burden is higher. And we assess the ZERID burden score with the caregiving burden of depression, and this also very much significant. You see the odds ratio, 7.02. This is very, very significant. And the moderate to severe burden is 12.7 odds ratio, very significant. And the association between emotions of anxiety, saying, all these are not very much significant, so I am skipping this. Here, the ZERID burden score in anxiety scale, it is also significant. The odds ratio 3.36 and 4.87. In case of stress, these are not significant, so I am skipping. Here, duration of cancer diagnosis is very much significant. Here also, for stress, 2.11 odds ratio. And the duration of caregiving, 6 months or more, this is significant for anxiety. Again, if we consider the association between caregiving burden and ZERID burden interview scale, it is very, very significant, 8.92 and 23.6. So in conclusion, we can say that among 290 caregivers included in the study, severe and extremely severe levels of depression, anxiety, and stress were found in 17.9%, 29%, and 13.1% respectively. Advanced stage of cancer was significantly associated with depression. Those who were caring for cancer patients more than 6 months and higher odds of depression and stress. There was no significant association between depression, anxiety, or stress with relationship of the caregiver, treatment cost, type of treatment received by the cancer patient, or caregiving responsibility. So these are only the figures. The true stories behind these are not fully depicted here, of sorrow, loss of job, selling of properties, and above all, dying of near and dear ones after a long suffering. Thank you very much.
Thank you, Dr. Nurizaman, for a beautiful presentation. I would now like to request Dr. Muhammad Abdullah Saeed, who is currently working as an assistant professor in the Department of Psychiatry in Northeast Medical College, Sylhet, Bangladesh. His topic of presentation will be Pattern of Sexual Dysfunction in Male Major Depressive Disorder Patients. স্কেপ করে ওই দুটো দেখাতে হলে স্কেপ করে আবার ওটা দেখাতে হয়। আপনি যে দুটো দেখাতে চাচ্ছেন 9 মিনিটে ফার্স্ট থেকে দেখাবেন।
Thank you, Dr. Nusrat Chand Tanjila, for introducing me. Honorable Chairperson, respected teachers, and dear colleagues, and learned audience, welcome to all in today's oral presentation session. My article of presentation is Pattern of Sexual Dysfunction in Male Major Depressive Disorder Patients. I am Dr. Muhammad Abdullah Saeed, working as an Assistant Professor, Department of Psychiatry, Northeast Medical College, Sylhet. My journal article is published in Archives of NIMH, 2021, Volume 4, Issue 1. At first introduction, the major depressive disorder is the most common psychiatric disorder. Sexual dysfunction is more common in major depressive disorder, which is an important cause of poor quality of life, as satisfying sexual experience is an essential parts of healthy life. Major depressive disorder is a leading cause of ill health and disability worldwide. Different studies show that the prevalence of major depressive disorder in Canada is 3.9%, in India 6%, and in Bangladesh 4.6%. Depressive disorder play a major role in sexual dysfunction. Domain of sexual function can be altered by depressive disorder. In general population, prevalence of sexual dysfunction in men is 31%, but in depressive disorder there is high rate of sexual dysfunction, like 55%. Management of major depressive disorder includes psychological, pharmacological and social treatment. Antidepressant improve sexual function. Antidepressant improve depression and often leads to restoration of sexual functioning, but sometimes it also causes sexual dysfunction. So it is important to assess sexual functions of a patient during the diagnosis of major depressive disorder. Although clinical observation indicates that sexual dysfunction in patients with major depressive disorder is relatively common, but there is no published data in respect to our population. These studies try to ascertain this problem. The objective of my study is to assess the pattern and frequency of sexual dysfunction in male major depressive disorder patients, to find out whether there is any correlation between severity of depression and sexual dysfunction, and to see the relationship between sexual dysfunction with socio-demographic variable of the patients suffering from major depressive disorder. In methodology, this is a cross-sectional observational study which is conducted in Department of Psychiatry, Sylhet MAG Usmani Medical College, Sylhet, during the period of September 2017 to August 2019. And married male major depressive disorder patients between 18 to 50 years of age are enrolled for this study. Total sample size was 68. And at first, major depressive disorder was diagnosed according to DSM-5 criteria. And socio-demographic information of the patients obtained by semi-structured questionnaire. Then, severity of depression was assessed by a DAS-21 scale. And then, Arizona Sexual Experience Scale was used to assess sexual dysfunction. And I show here result of my study. In study, there is high rate of sexual dysfunction, like 70.5%. Among them, low sexual desire and difficulty to reach orgasm are the most prevalent psychiatric disorder, the most prevalent sexual dysfunction. Another problem are arousal problem, difficulty in erection, difficulty to reach orgasm. And in this study, regarding severity of depression, 14.7% are mild depression, 27.9% are moderate, 17.6% with severe depression, and 39.7% are extremely severe depression, which is assessed by DAS-21 scale. And in there is a table to see the association between sexual dysfunction and socio-demographic variable. In here, we use chi-square test, and this table shows there is no statistically significant relationship between sexual dysfunction and demographic profile like age, religion, education, occupation, residence, monthly income, and family history of psychiatric illness. And Pearson correlation metrics show sexual dysfunction is correlated with severity of depression, but there is no correlation between sexual dysfunction and duration of major depressive disorder. And now comes to discussion. This study found high rate of sexual dysfunction in major depressive disorder, which is comparable to the result of Thakurta et al. And Kendurkar and Kaur. They found 71.6% and 76% respectively. And findings of this study is compatible with prospective Zurich cohort study, which show the sexual dysfunction is approximately twice in major depressive disorder patient. And in my study, low sexual desire has frequently been reported problem, which is comparable with another study where the 33% and 42%. And another problem is low arousal was present in 62.2%, 2% patient, which is different from study of Kendurkar and Kaur and Thakurta et al., where it is 32.2% and 8.33%. This difference might be due to difference in socio-demographic variable. And difficulty in erection was found in 23.5% of major depressive disorder patient, which is comparable with the result of Thakurta et al. And Kendurkar and Kaur. And Shakhari et al. Reported 76% have erectile dysfunction, which is not matched with the present study. This variation may be due to use different rating scale. And difficulty to reach orgasm was 35.3% in this study. This finding was comparable with Kennedy et al. And Matthews and Windman. And findings of this study different from Kendurkar and Kaur and Thakurta et al. This difference might be due to different in marital status and social factor. This demographic factor and social factor variation leads to variation in the study result. And the present study found problem in orgasmic satisfaction in 33.8%, which is almost similar in Maru et al. And Kendurkar and Kaur et al. And this findings is inconsistent with some study. This inconsistency may be due to different stages of different inclusion criteria and technique of assessment. And this study shows a strong positive correlation between severity of depression and sexual dysfunction, which is also reported in different studies. And in two studies, they do not find correlation between severity of depression and sexual dysfunction. This difference can be explained on the basis of sample size, socio-cultural difference, and difference in socio-demographic profile. And in this study, there are no statistically significant correlation between duration of major depressive disorder and sexual dysfunction. Duration of major depressive disorder and sexual dysfunction. And now conclusion, regarding conclusion, this study revealed significantly high frequency of sexual dysfunction in patients with major depressive disorder. All the domains of sexual functioning were affected by major depressive disorder. Hence, this study emphasized the need for awareness and importance of inquiring about sexual dysfunction in major depressive disorder patients. And there is a recommendation that further multi-center study are required to evaluate the actual scenario in Bangladesh. And these are the references of this study. Thank you all for patience hearing.
Now it is time for our third and final presentation, which will be delivered by Faiza Ahmed, who is currently working as Senior Instructor of Child Psychology in Shishu Bikash Kendra of Hospital Services Management of DGHS. Her presentation topic will be Understanding the Relation of Childhood Trauma, Trauma Experiences and Demographic Features of Children on the Risk of Developing PTSD. I'm requesting Faiza Ahmed to take the dais and deliver her presentation.
Good evening. I'm Faiza Ahmed. I'm a child psychologist working long years the child psychology, child and adolescent psychology. First of all, I want to start with my experience. Actually, I do clinical practice with child and adolescent mostly, And I see that some children comes to me, they become very resilient, but they experience lots of trauma experiences. And some become, apparently it shows that they are very in a healthy family environment, but they become very passive. That's the background. So, today the title of my paper is The Understanding the Relation of Childhood Trauma Experience and Demographic Features of Children and the Risk of Developing PTSD. I'm the main author, and the co-authors Dr. Muhammad Kamruzaman Muzumdar and Dr. Mahfuz Khanum. Okay, about trauma. It's from DSM-5, exposure to actual or threatened death, serious injury or sexual violence in one or more of the following ways. Basically, directly experience the trauma event. Someone might witness trauma. They can be traumatized. Also, learning about the traumatic event occurred to their close family member. And also, if it happens sometimes that a traumatic event happened, the child is doing okay, but the investigator like police and other people, the law and investigating people interview them many times and they become traumatized. So what is trauma and childhood trauma? In a brief, trauma is the result of an extreme amount of fear or stress with which person cannot easily cope, and childhood trauma is defined as the experience of an event by a child that is emotionally painful or distressful, which often result in lasting mental and physical effect. And PTSD. PTSD, in brief, I can say that there must be it's same as trauma, but there is some other 4 criteria. Like they will have intrusive thought, avoidance behavior, arousal, and a negative mood. And PTSD in a child, they might have sleeping problem, lose interest in enjoyable thing, detached or numbed and non-responsive. They can be, it's very common, depressed, trouble with affectionate feeling, avoidance, withdrawal behavior. They become very nervous, alert. We know about the fight or flight mode, aggressive and violent. They may have flashback. Commonly they come with the school problem, trouble in focusing in anything, somatic symptom. They come to us like headache and sometimes the other somatic pain. The child may believe the event is happening again and again. They lose the control with the reality. They become very worried about dying at a young age. At younger than their age, we see that they have some regression in their functional state. So this is the cycle of childhood trauma. It's a kind of transgenerational trauma part. Like if a child is experiencing a childhood trauma, if the child is not get treated, they might have problem emotional, cognitive, behavior, and then it become adolescent and behavior and mental health problem. Then it become the adult mental health problem and impaired caregiver, and it comes to another childhood trauma. So it's a transgenerational. So what are the consequences of PTSD? Brain development, IQ or intellectual development, learning difficulties, executive functioning, that is very important part. Attachment and relationship problem, behavior problem, emotional problem, psychological illness. They have logical thinking problem, problem solving, sustain and focus attention, planning, language problem, abstract reasoning, and coping mechanism. Basically, if I want to say in a brief part that they have problem in their coping strategy and their developmental part. So the main objective was, the main aim of the present study is to see the relationship among demographic factors and different types of childhood trauma exposure on the risk of developing of PTSD. In this study, we used survey research design. Total 397 child was included, and it was a pervasive sampling technique. And participants were selected from 14 different districts of Bangladesh. So, if you see the areas, Dhaka, Borishal, Nilphamari, Feni, Rangamati, Potuakhali, Khulna, Gopalganj, Natrol, Kurigram, Naga, Jaipurhat, Sirajganj, Manikganj. So total 14, basically total 15 trained child psychologists selected data because it's a very sensitive issue. So, and the inclusion criteria is 9 to 13 years on enrollment, and the exclusion criteria is severe neurological and psychiatric disorder, severe developmental disability, and severe intellectual disability because it's an interview method. We use the measures of socio-demographic questionnaire, the child impact of event scale, and child and adolescent trauma experience checklist. So CRISE is a very commonly used checklist, and it's adapted in 15 countries. It's the Bangla adaptation from Dr. Farah Diba. And the child and adolescent trauma checklist, it's a 21-item Bangla checklist. It's about the trauma experiences. It's custom-made, item developed by the researcher and checked by the expert. So the procedure is of volunteer participation was ensured. We take the parental consent and assay obtained as necessary based on the age of the children, and the participant and their legal guardian provided detailed description about the purpose and procedure involved in this research. So we take the participant from school, madrasa, and from nuclear families, like joint family, also from the foster care. The result, the demographic part, when we do the one-way and over table analysis, we see that it's like all the same, like the females are more prone to develop PTSD. You see the inclusive part is more in the female, like the girl, and the other part, we selected like 21 trauma experiences, but here we see 11 types of trauma experience who have the more score, higher mean score of crime is the natural disaster, severe physical abuse, threat of physical abuse from a family member. It's very common in Bangladesh. Death or severe injury of close one, sexual abuse, and the newer part is that COVID, like someone very close infected in COVID. And when someone very close infected in COVID, when the child was in risk of the infection of COVID. And death of a family member for COVID-19 and other. There are some uncommon other trauma experience, because there is a question, is there any other trauma experience? So one child was reporting me that she could not get not chance into the the desired school, and she was very traumatized. And one child was reporting me the change of their house, the old house. They give it to the developer, and she become very, very traumatized, and she has flashback of that previous house. So the conclusive part and what coming to my mind is like various childhood trauma exposure increase the risk of developing PTSD. It's very clear. And COVID-19 situation have a huge impact on developing PTSD in this child group, 9 to 13 years. And girls have higher score in CRISE, need to consider a planning for PTSD screening for children with other mental health issues. That's my main suggestion. Because when I do my clinical practice, I have planned to do some small screening for PTSD. Because in this situation, children started their school and they are in lots of pressure. And they have many trauma symptoms. So that might, you see the trauma cycle, if we can help them, we can break the cycle. So. That's my thought. That's a reference. Thank you so much.
We are done with all the presentation part of the sessions. Now it is time for question and answer session. If any of the audience have any questions regarding any of the presentations, please write it down and we will convey the question through our chairs. Does anyone have any questions regarding any of the presentations? If there is no questions, then I'd like to move on to the next part of our session, which is our valuable comments from our respected chairs for all the presentations. I'd first like to request Professor Muhammad Shafiul Hassan sir to comment on the presentations and about all the presenters.
Honorable Chairperson, my fellow colleague, distinguished participants, ladies and gentlemen, Assalamu alaikum. I must thank our organizers of Psychiatric Association of Bangladesh for selecting me in such a occasion in which we will learn many things from this presentator discussion. I would like to thank our my presentators for their elaborate discussion. First of all, I would like to talk about the patients, cancer patients, caregivers, mental health, presented by our brilliant presenter, Dr. Hassan Shahriar. We know that in our country, particularly, people stay in the rural areas, most of the people, so they suffer from cancer. They know that cancer has no answer. Still, we have the way to find out the patient, but I have seen that even my family member, well, still I can remember, my sister, she was educated. She came to my spouse, who was a gynecologist, in advanced stage of ovarian tumor. And she palpated her abdomen, it was grade 4. You can see the patients from rural areas in cancer patients. They are treated by the traditional healers, religious therapists, and non-scientific medications. And ultimately they come to a specialist in the tertiary hospital for getting treatment. But it's difficult to treat at that stage, as we all know. And from our discussion by Dr. Hassan Shahriar, he really focused on the burden of the caregivers regarding the treatment of the cancer patients. It's really a difficult subject. From his discussion, we are really benefited for our future caregivers of patients. Actually, the patients suffer from psychological disorders like anxiety, depression, and suicidal thoughts and attempt. But the caregivers, they suffer more, they become helpless and by different psychiatric problem due to the consequence of the disease. So I think this is a time-tested discussion in this Psychiatric International Conference. Second presenter, Dr. Abdullah Saeed, he talked about the sexual dysfunction of male major depressive disorder. It is really very correct that we know that the psychiatrists, in major depressive disorder, biological symptoms become prominent. And one of the part of this biological symptom is the sexual dysfunction, which is very much important to assess the depressive disorder and its complications like sexual dysfunction. So must remember, during the treatment of the depressive disorder, this particularly like the suicidal thoughts and suicidal attempt, we must think about the sexual dysfunction, and we should treat properly. In addition to the antidepressant, we think about the sexual function, which is a very important part of our life, family life particularly. So this is very important topic. We are really benefited. The learned audience, I think they'll be benefited from his discussion on sexual dysfunction during the depressive disorder period. Last of all, I would like to focus on the trauma experiences in childhood which lead to post-traumatic stress disorder. We know that the children are very much vulnerable for their hyperactivity and some behaviors which may not be the disorder. But the easy way of controlling the hyperactivity or their behavior, the easy way, particularly in our developing country, by punishment, which is strictly prohibited by the psychiatrists for modern psychiatric treatment, unless it is dangerous for the individual or for the society. So in our country, we have seen that the children are traumatized in different ways. Verbal abuse, physical abuse, and bullying, these are very common, even in today's academic institution and many other organizations. So this is a very important topic which was discussed by Faiza Ahmed in details. I think if we can break the traumatic cycle in some stage of the traumatic events, then we can stop the development of post-traumatic disorder in later stage of their life, particularly adult life. We know that the childhood trauma or childhood disease may lead to the adult stage like phobic anxiety disorder. So this is a very important topic in presenter Faiza Ahmed for detailed discussion regarding the child, because they are very important part of our nation. So we should be careful, we should prevent the childhood trauma by different ways like media and some other agency. So in these few words, I like to conclude. Before conclusion, I must thank everybody for patience hearing and sincere cooperation. Thank you very much.
Thank you, sir. Now I would like to request retired Brigadier General Professor Ashfaquzzaman Chaudhary, sir, to give his valuable comment regarding all the presentations.
Assalamu alaikum. Thank you very much for giving me a chance to be here as the chairperson. Thanks to the Bangladesh Civil Psychiatry Association. So it's a good honor, and I think I'm really benefited by the lecturers who has given such a good lecture in a very short time. They informed us a lot of things. So first lecture, Professor Hassan, he is wonderful. This is surprising. This is all the time he's talking very good things. And he being a surgeon, the way he uttered about the difficulties the caregivers are facing really in treating the cancer patients. So wonderfully he mentioned about because of the causes, the less facilities, the very expensive nature, and the complex nature, and the long durations, and the burden really which these people are facing. So I think he gets very good, very many thanks from our side that he is really giving a new sight for the caregivers, because they really require restraint from the pain they undergo. So thank you very much for the presentation. That was a wonderful presentation. I think people will come forward to give more presentations about these subjects. And the second one was by Professor Abdullah Saeed, the sexual dysfunction and the depressive. This is very common symptoms that are likely to happen in case of patients who are really suffering from the major depressions to have sexual problems. But the thing is that at times, this is to be very cautious about that when patients, it might happen the patients come only with the symptoms of the sexual dysfunctions, not with the depressive features, because that even masked at times. So that is to be very careful that patients having sexual disorder might have the depressive disorder. So ultimately it comes out that actually he was suffering from the depressive disorder and you need to treat him accordingly. So that's a wonderful part. He has come out and he has shown the difficulties faced by the patients with erectile difficulties, low arousals, and the low desire, etc., and orgasmic problems. So I think that was a good side, and that was a good way of presentations, and we really learned a lot about it. And the third presentation was by the Faiza Ahmad, his instructor on child psychology. That was wonderful presentations, and really she mentioned about the trauma, the PTSD the children are really facing. This is to be focused very carefully, because they are our future, and if they really undergo PTSD, which their features actually comes out when they are adolescents and adults. Initial stages, people might make a different diagnosis, not thinking about the trauma which they are undergoing and developing the PTSD. Because, and which Professor Shafil Hassan really mentioned about, that these patients is to be dealt very carefully, because not by punishing only. You need to see what trauma really they've undergone, you need to be sympathized, you need to be very cautious, and need to be give a good environment so that really they do not suffer further. And then at the same time, you need to treat the patient for the PTSD. That is very, very dangerous, because if it continues in that way, ultimately very ending results can come when they are in adolescent period or just an adult. So thank you very much for the wonderful presentations by Faiza Ahmad. That was really gave us many new learnings. Thank you very much indeed.
Thank you, sir, for your valuable comment. Now, the question-giving portion of the session and the end portion of the session, I would like to request the honorable chairs to award the presenters with the requests. Sir, could you please come in front of them?
স্যার ওয়াজির রহমান স্যার আপনাদেরকে প্রেস দিবেন স্যার। ওয়াজির স্যার তো ছাত্রকে প্রেস দিবেন। হ্যাঁ, পরে পরে, এখন না, পরে।
So, of course, Dr. Hassan Shahriar is the man for his beautiful presentation. Dr. Abdullah Saeed for his beautiful presentation. Faiza Ahmed for her very timely and important presentation. Now, I'd like to ask the President of Bangladesh Association of Psychiatrists, Professor Wazir sir, to honor our chairs with their crests, sir.
So, as a president of the organization, I'd like to offer my heartiest thanks to our brilliant chairperson of this session, Raspak ebong our beloved Hassan Bhai. And regarding the speaker, actually all the papers are very, very useful, rather I should say, very useful. Like Nuruzzaman presented the psychological aspect of cancer, it was supposed to be carried out by a psychiatrist. On the other hand, it has been carried out by a surgeon. Though Kollol is our very, very good colleague of psychiatry, he worked there for 3 years. Even I am really, really very thankful to and congratulate Dr. Nuruzzaman for this presentation. The second is Ahmed Said. The paper he prepared is really very difficult because, you know, particularly the sexual dysfunction and drug addiction, these are very difficult aspects of our life, and usually people often hide their problem. So making a paper in this aspect is really difficult, and he has done a very hard job and very useful job for everybody, not only for psychiatrists, for every professionals. And finally, Faiza has made a wonderful paper that it is also very useful because children are the future of the nation. Now, how a trauma in childhood make a vicious cycle and make the children a patient of PTSD. So thank everybody, congratulations, thank you.
All right.